A very good evening, everyone. So, after having discussed about the cardiac emergencies, pulmonology emergencies, neurology emergencies, and in the today's session, we'll be discussing the nephrology emergencies. So, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. So, in this particular session, I'll discuss like what are the various forms with which renal failure patients they present to the emergency or they present to the casualty. So these are all the abnormalities that can make a renal pathology patient presenting to the casualty in an emergency situation. One is the electrolyte abnormalities. What are those? I'll tell you. Then second important emergency situation where the nephrology patient can present to the casualty will be metabolic acidosis. Then uremic encephalopathy is another important emergency situation in the nephrology. Then hypertensive encephalopathy, and then dialysis related complications. So these are the nephrology emergencies with which the patient can present to the casualty, right? And now out of which, let me take up the first important thing, that is the electrolyte abnormalities. Now, what are all the various electrolyte abnormalities that a patient can present to into the casualty related to the nephrology? Right. Yes. Hello, everyone. Good evening. So, these are all the various electrolyte abnormalities with which the patient can present to. One is hyperkalemia, hypokalemia, hypocalcemia, and then the hypermagnesemia. So, these are the electrolyte abnormalities that can be seen in renal failure patients. Now, in all these electrolyte abnormalities, the first and foremost, the very important thing is you need to know like what is the cause of death in these individuals. In all these clinical scenarios, what is the cause of death? So first and foremost, like you take in patients with the hyperkalemia. In hyperkalemia, the cause of death will be diastolic arrest. Right, the cause of death will be diastolic arrest. Whereas in patients with hypokalemia, can the hypokalemia occur in renal failure? Yes, it can happen. And what exactly is the etiopathogenesis? I'll tell you. And the cause of death will be respiratory paralysis. And the third important electrolyte abnormality that can be seen in case of the hypocalcemia, that would be the cause of death in hypocalcemia will be laryngospasm. And the next important is the hypermagnesemia. Hypermagnesemia is another important electrolyte abnormality that can occur in renal failure, and the cause of death in these patients will be the heart block, and it could be also even respiratory paralysis causing respiratory failure. Okay, so these are the these are the four important electrolyte abnormalities that can happen in renal failure. Now let us talk about the etiopathogenesis, in the sense like how does this electrolyte abnormalities occur in case of the renal pathology patients. So first is the hyperkalemia. So why does the hyperkalemia occurs? Hyperkalemia occurs because there is impaired excretion of potassium in renal failure patients. Okay, so the etiopathogenesis is impaired excretion. Right, that will be the cause for renal failure in case of, that will be the cause for hyperkalemia in renal failure, that is impaired excretion of potassium. Now the question is, why does and how does the hypokalemia occur in patients with the renal failure? Now hypokalemia, it occurs in a scenario where there is decreased renal perfusion to the kidney and causing renal failure. I'll repeat the point again. Why does the hypokalemia occur in a renal failure? If the etiology of renal failure is due to reduced renal perfusion to the kidney and causing kidney failure. Now what happens? Whenever there is reduced renal perfusion to the kidney, there will be excessive activation of renin-angiotensin-aldosterone system. And once there is excessive activation of renin-angiotensin-aldosterone system, there will be increased aldosterone which is being produced. Now, what is the effect of aldosterone on the potassium? It will cause potassium excretion, resulting in hypokalemia. So, hypokalemia can also occur in renal failure, but it all depends upon the etiology causing renal failure. Now, why does the hypocalcemia occur in patients with renal failure? That is because the kidney is the place where the vitamin D synthesis has to occur, and if the kidney is damaged, there will be decreased vitamin D synthesis, and because of decreased vitamin D synthesis, calcium absorption at the level of the intestine does not occur, and that will result in the hypocalcemia. And what is the very important enzyme which is required for active form of vitamin D synthesis within the kidney? That is 1-alpha hydroxylase. 1-alpha hydroxylase is the enzyme which is present in the proximal convoluted tubule of the kidney, and that enzyme is required for formation of active form of vitamin D. And this active form of vitamin D is called calcitriol, and this calcitriol from the kidney it goes to the level of the intestine. At the level of the intestines, it will cause the reabsorption of calcium. And whenever there is renal failure, vitamin D synthesis does not occur. Because vitamin D synthesis does not occur, the calcium absorption at the level of the intestine does not occur. Okay. And what would be the cause of death? That is your laryngospasm. Next is hypermagnesemia. What would be the cause for hypermagnesemia in patients with a renal failure? That is again because of impaired renal excretion. Right, that is again because of the impaired renal excretion. That is what is responsible for the development of hypermagnesemia in patients with the renal failure. Now you should know the individual clinical features, right? You should know what will be the individual electrolyte abnormality clinical features. Depending upon the clinical presentations, you know, you should be able to make out like what is the electrolyte abnormality the patient is having. Like you take patients with hyperkalemia, as such, like these patients, they present with the heart block, right? They present with heart block or bradycardia. So whenever there is bradycardia, what do you think would be the clinical presentation? That is giddiness, right? That is giddiness. Okay, that is what will be the presentation in case of the hyperkalemia. Why is that? That is because of bradycardia and as well as the heart block. Then the next important is the ECG changes in case of the hyperkalemia. So ECG changes in hyperkalemia. What is the earliest ECG change in hyperkalemia? That will be tall T wave. Can anyone tell me what is the differential diagnosis for the tall T wave? Yes, can anyone tell me what will be the differential diagnosis of the tall T wave? Okay, so if you see the differential diagnosis of the tall T wave, you can have this particular tall T wave even in patients with the MI. But the difference is that in case of the hyperkalemia, you will have narrow tall tented T wave, whereas in MI, it will be a broad tall T wave. That will be the difference between MI tall T wave and as well as the hyperkalemia tall T wave. Okay, right. So now these will be the ECG changes that you will see in patients with the hyperkalemia. Right. So this is the normal ECG, and as the hyperkalemia goes on, so there will be tall T wave, tall tented T wave. Then subsequently, what will be the right? Subsequently, what will be the other ECG changes? The other ECG changes that you will have is you will have prolonged PR interval. That means the PR interval will be more than 200 milliseconds, and the P wave it becomes flattened. And later on, the other important ECG changes is the P wave completely disappears and the patient will develop bradycardia. Right, the patient will develop bradycardia. So once there is development of as the hyperkalemia still progresses, the individual will have cardiac arrest. Right, the individual will have development of cardiac arrest. Okay, so these will be the ECG changes in patients with hyperkalemia. Initially tall tented T wave. So when you are using the word tall tented T wave, what should be the amplitude of the T wave? Amplitude of the T wave should be more than 10 mm. Followed by that, the other ECG changes are prolonged PR interval, and then the P wave will become flattened. At one point of time, the P wave disappears and there will be bradycardia. So this particular pattern, we call it as the sine wave pattern. Right, this particular pattern of the ECG is called as sine wave pattern. And sine wave pattern, please remember, it is very much classical in patients with the hyperkalemia, right? So that was about like how will you diagnose the hyperkalemia. So one is your ECG changes, and the next important is what you can also test for the potassium levels. You also need to test for the potassium levels. Then the next important is like the treatment. So what do you think is the drug of choice in these patients with hyperkalemia? What will be the drug of choice in patients with hyperkalemia? Any one of you? So the drug of choice will be calcium gluconate. right? Drug of choice will be calcium gluconate. So you have to give 10% calcium gluconate, and this 10% calcium gluconate should be diluted in 10 ml of NS, and you have to give it intravenously over 3 minutes, and you have to repeat it after 5 minutes if necessary, right? You have to repeat it. Yes. Yeah. So now what is the purpose of doing giving calcium gluconate is, remember, this calcium gluconate will not reduce the potassium levels. Calcium gluconate will sensitize the myocardial membrane against the cardiac arrhythmias. That is the purpose of giving calcium gluconate. So calcium gluconate will not reduce the potassium. It will only sensitize the cardiac membrane against the arrhythmias. Now, next to the calcium gluconate in the treatment, the other important molecule is the calcium chloride. Now, okay, instead of calcium gluconate, what is the indication for giving calcium chloride? Any one of you? Instead of calcium gluconate, what is the indication for giving calcium chloride? Okay, so the indication for giving calcium chloride is that a patient with hyperkalemia, if suppose he has developed circulatory shock, then then you have to give the calcium chloride. And this particular calcium chloride, whenever you give, the effect will last for nearly around 30 to 60 minutes. 30 to 60 minutes. Okay, so that is about your calcium gluconate when to give and calcium chloride when to give. And what are the drugs which will reduce the potassium levels? See, there are certain drugs which will cause transcellular shift of the potassium, and there are certain drugs which will cause the potassium removal. So the drugs which will cause transcellular shift of the potassium from extracellular compartment to the intracellular compartment will be the insulin, right? So the drug what you can give is the insulin. So now this particular insulin, it has to be given along with dextrose, right? So what is the purpose of giving dextrose along with insulin is that whenever you are giving insulin infusion, it is very good that the potassium get corrected, but the problem is that the patient will land up in hypoglycemia. So in order to see that the patient does not go into a state of hypoglycemia, like, you need to give the dextrose solution. Okay, right? And what are the drugs which will remove the potassium? The drugs which will remove the potassium will be the oral K-xylate. We call it as the potassium binders. We call it as potassium binders, that is called oral K-xylate. And the other drugs which can be useful is the beta 2 agonists. Even these particular drugs can also reduce the potassium levels. Okay, so this is about one of the important nephrology emergency, that is hyperkalemia, right? Nephrology emergency, that is hyperkalemia, right? Now, after having discussed about the hyperkalemia as one of the important nephrology emergency, now let me discuss the second important nephrology emergency, that is the hypokalemia. So if you take hypokalemia, can it happen in renal failure? Yes, it can happen. So what is the mechanism I have taught you? So any condition which is causing decreased renal perfusion will cause the activation of RAS. Now, once there is activation of RAS, there is excessive aldosterone production causing potassium excretion, resulting in hypokalemia. Now, what will be the clinical features in patients with the hypokalemia? So if the question is asked, like, what is the earliest manifestation in hypokalemia? That will be development of muscle cramps. That will be development of muscle cramps. And what are the other important features of the hypokalemia is, the gastrointestinal motility will be reduced, so the patient will present with ileus. The patient will present with decreased gastrointestinal motility, due to which the patient will present with ileus. Okay, and the other important is they will develop respiratory muscle paralysis. They will have the flaccid paralysis of the respiratory muscles, right? There will be flaccid paralysis. Now, once there is flaccid paralysis, the individual will end up in type of respiratory failure. So can anyone tell me what is the type of respiratory failure that you will see whenever there is respiratory muscle paralysis? What will be the type of respiratory failure that you will see whenever there is respiratory muscle paralysis? Any one of you? So the type of respiratory failure that you will see whenever there is respiratory muscle paralysis is type 2 respiratory failure. So whenever there is type 2 respiratory failure, what will happen to the carbon dioxide levels? The carbon dioxide levels increases, right? So there will be hypercapnia, right? There will be hypercapnia. Very good, Mohammed. So it is type 2 respiratory failure, so thereby there will be hypercapnia. Now the next important is the ECG changes that you will have in patients with the hypokalemia. So like, what will be the earliest ECG change is, you will have the appearance of the U wave, then followed by that you have the T wave being flat or inverted, So there will be prominent U wave that you will see within the precordial leads, and followed by this you will have the T wave which is being flat or being inverted. Then what are the other ECG changes that you will have in patients with hypokalemia is the QT interval, right? So these are all the ECG changes that you will see in patients with the hypokalemia. So number one, there will be prominent U wave. Then followed by that, there will be T wave inversion. Followed by that, you have a long QT interval, right? Followed by that, there will be long QT interval. Okay. So how much will be that QT interval? So if you see the duration of the QT interval, so it is around 360 to 440 milliseconds will be the QT interval. So in these individuals, the QT prolongation will be there. And this QT prolongation is not just seen only in hypokalemia. Hypocalcemia can also cause QT prolongation. Hypomagnesemia can also cause QT prolongation, and even hypermagnesemia can also cause the QT prolongation. So these are all the conditions where there can be QT prolongation. Okay, so these are the ECG changes that you will have in patients with the hypokalemia. Then how do you treat these patients with hypokalemia? Okay, diagnosis of the hypokalemia is that, like, you will do the serum potassium levels, right? You will check for the serum potassium levels, and not only testing for the serum potassium levels, the next important thing is you also need to do the ECG. Now, how will you treat these patients with the hypokalemia? See, the treatment of hypokalemia is that you need to give potassium chloride, right? You need to give potassium chloride. Now, see, one more important point in the ECG is there will be long QT interval, and this long QT interval can progress to the development of Torsades de Pointes, right? Can progress to the development of Torsades de Pointes. That is another very important point that you have to remember. Okay, now treatment is, so if the potassium levels are in between 3 to 3.5, you need to give oral potassium chloride, right? Whereas the potassium levels are less than 3 milliequivalents per liter, then you need to give intravenous potassium chloride, right? Then you need to give intravenous potassium chloride. So this is very, very important, how you have to treat this particular hypokalemia. And what is the cause of death in patients with hypokalemia? That is respiratory muscle paralysis or even tachyarrhythmias. So what is the cause of tachyarrhythmias in patients with the hypokalemia? Because of prolonged QT interval. So this prolonged QT interval can progress to the development of Torsades de Pointes, which is nothing but your VT or VF, and then the individual can have a sudden cardiac death. So that is second electrolyte important abnormality in case of the renal failure. Next, third important electrolyte abnormality that you need to know in case of the renal failure, because of which, right, because of which the patient can present to the emergency department, is the hypocalcemia. See, these patients with hypocalcemia, they can die. What would be the cause of death in patients with hypocalcemia? As already I have said you, that is laryngospasm, right? Then what would be the clinical presentation in case of the hypocalcemia? So the cause of death will be laryngospasm, right? And the clinical features will be perioral paresthesias, right? Not only perioral paresthesias, there can be even periungual paresthesias. Okay, so perioral and as well as the periungual paresthesias. And the next important is these patients with hypocalcemia, they can also have tetany. They can also have tetany. Okay, right. And yes, Zaidi, you can get this particular PDF. I'll just post it on my Telegram channel, that is Medicine Made Easy by Rajesh Gubba. So you can take this particular PDF from there. Okay, right. And ECG abnormalities in patients with hypocalcemia is that there will be prolonged QT interval, right? There will be prolonged QT interval. So QT interval, when it is prolonged, how much it will be? It will be more than 440 milliseconds. Then how do you treat these patients with hypocalcemia? So treatment with hypocalcemia is that you need to give intravenous calcium gluconate, right? You need to give intravenous calcium gluconate. And once the individual is stabilized, then you can give oral vitamin D and as well as calcium gluconate. So oral vitamin D and as well as oral calcium gluconate has to be given. Okay, right. And etiopathogenesis for hypocalcemia is what? Etiopathogenesis for hypocalcemia is whenever there is renal failure, there is decreased vitamin D synthesis, and because of decreased vitamin D synthesis, the calcium absorption at the level of the intestine will not be there, and that will result in hypocalcemia. So what would be the presentation of the patient to the emergency department? The presentation is laryngospasm. Whenever there is laryngospasm, what the patient will have? The patient will have stridor. Right, whenever there is laryngospasm, the patient will have stridor, and if you don't treat that, then immediately the patient can die. Okay, then coming to the hypermagnesemia, right? So already I have taught you like the etiopathogenesis of the hypermagnesemia. What is the etiopathogenesis for hypermagnesemia? The etiopathogenesis is impaired excretion of magnesium from the impaired renal excretion of magnesium. And what would be the cause of death in these individuals? Again, same story, that is respiratory failure, and even there can be development of the heart block. Even there can be development of the heart block. Now the question is like, what will be the clinical features whenever there is hypermagnesemia? First of all, you should know how much is the normal value of the magnesium. Right, first of all, you should know how much is the normal value of the magnesium. See, the normal value of the magnesium is, it is 1.5 to 2 milliequivalents per liter. Okay, 1.5 to 2 milliequivalents per liter. That is the normal value of the magnesium. Right, now depending upon the magnesium levels, you will have the clinical manifestations. Right, the clinical features completely depends upon the severity of the hypermagnesemia. Like for suppose, right, like for suppose, normal value is how much? 1.5 to 2. If the magnesium levels are 3.5 to 5 milliequivalents per liter, there will be absent deep tendon reflexes, and there will be also muscle weakness whenever the magnesium levels are in the range of 3.5 to 5 milliequivalents per liter. And when the magnesium levels are 5 to 6 milliequivalents per liter, the patient will have hypotension and as well as vasodilatation. Right, vasodilatation and hypotension will be there. And when magnesium levels are 8 to 10 milliequivalents per liter, the patient will develop arrhythmias. And which type of arrhythmias are very common in case of hypermagnesemia? That will be the atrial fibrillation. And there can be also muscle paralysis. Right, there can be also muscle paralysis. And when the magnesium levels are more than 10 milliequivalents per liter, that is the point when the individual will develop the conduction block and death. Right, the individual can develop conduction block and as well as death. So these will be the the clinical features in patients with hypermagnesemia depending upon the levels of magnesium. Right, and what would be the cause of death? I have said you, that is conduction block, and finally death of the individual. Right, and the next important point, what you have to know is the ECG changes. Right, so clinical features already I have discussed. Right, and ECG abnormalities. So ECG abnormalities, if you observe very carefully, even in patients with hypermagnesemia, there will be QT prolongation, right, and there will be wide QRS complex. So right, so remember now, very important point, that the QT prolongation is not just seen only in patients with hypomagnesemia. Even in patients with hypermagnesemia, there can be the QT prolongation. Now you should know the mechanism why there will be QT prolongation in case of the hypermagnesemia. See, whenever there is hypermagnesemia, this increased magnesium levels will inhibit the release of parathormone. Right, this increased magnesium levels will inhibit the parathormone release, and once the parathormone release is inhibited, that will inhibit the calcium reabsorption. Okay, so once calcium absorption is not there, then the individual will have hypocalcemia, and whenever there is hypocalcemia, there will be a QT prolongation. Right, there can be QT prolongation. Right, then next important thing is, how do you treat these patients with the hypermagnesemia? So you should give the IV fluids. The treatment is, you need to give IV fluids. So this particular IV fluids like sodium chloride, that will reduce the chance of the cardiac toxicity. Okay, so that will reduce the heart block. And the next important thing is, you need to use magnesium free cathartics that may clear the ingested magnesium from the gut. So magnesium free cathartics. So what this magnesium free cathartics will do? This magnesium free cathartics may clear the ingested magnesium from the gut. So that is how you will treat this hypermagnesemia, right? And so that completes the electrolyte abnormalities. So what did we discuss? The nephrology emergencies that can present to the casualty. One is electrolyte abnormalities: hyperkalemia, hypokalemia, hypocalcemia, hypermagnesemia. Hyperkalemia, cause of death, right? What is the cause of death in case of the hyperkalemia? That is because of your arrhythmias, right? And that is diastolic arrest. And what is the cause of death in hypokalemia? Respiratory muscle paralysis. And hypocalcemia, what is the cause of death? Laryngospasm. Hypermagnesemia, what is the cause of death? Heart block, and as well as even respiratory failure as well. Okay, right. Now, after having discussed about the metabolic abnormalities, now that is electrolyte abnormalities, now let me discuss the next two important abnormalities, that is uremic encephalopathy and as well as the hypertensive encephalopathy. See, uremic encephalopathy, why does it occur? Because the urea is the electrolyte or the metabolic substance that has to be, okay, so urea is a metabolic waste product that has to be excreted through the kidney, and whenever there is renal failure, the urea levels increases, and this increased urea, it will cross the blood brain barrier, and once it crosses the blood brain barrier, the urea will get accumulated within the brain, resulting in the uremic encephalopathy. And what will be the presentation is, the presentation will be in the form of altered sensorium. The patient can also present with seizures, or the individual will be in a state of confusion, and there will be asterexis. So what do you understand by the word asterexis? Asterexis is nothing but your flapping tremors. The flapping tremors are nothing but your asterexis. And there are differential diagnoses for your asterexis. Hepatic encephalopathy, you can have asterexis. Uremic encephalopathy, you can have asterexis. And carbon dioxide narcosis, you can have this particular asterexis. Okay, then how will you diagnose? The diagnosis is by, you will see that there is increase in the urea levels. Then how do you treat these patients with the uremic encephalopathy? See, the treatment in patients with uremic encephalopathy is the dialysis. So one of the very important indication for your hemodialysis will be the development of uremic encephalopathy. And another point is, the another important emergency complication of your uremic encephalopathy is, there can be even development of cardiac tamponade, right? There can be even development of the cardiac tamponade. Okay, so cardiac tamponade is what, where there can be abrupt accumulation of the fluid in the pericardial space, because of which there will be diastolic collapse of the ventricle. And because of diastolic collapse of the ventricle, what does these patients present with? These patients, they present with sudden onset dyspnea. These patients with cardiac tamponade, they present with sudden onset dyspnea. And you need to do emergency pericardiocentesis. And if you don't do emergency pericardiocentesis through subxiphoid approach, what you will be seeing is the death of the individual. Okay, and how will you diagnose cardiac tamponade? By doing a 2D echo. So 2D echo will show you that there is diastolic collapse of the ventricle in case of the cardiac tamponade. Okay, right. So that is one important emergency situation in nephrology, uremic encephalopathy. That is, the CNS manifestations can be there, or secondary to uremia, there can be even cardiac tamponade as well, so because of which the patient can present with sudden onset dyspnea. Okay, right. And in cardiac tamponade, I hope everyone is aware of this particular Beck's triad. What is that Beck's triad? Hypotension, raised JVP, and then muffled heart sounds. These three are your Beck's triad: raised JVP, hypotension, and as well as muffled heart sounds. And this raised JVP in case of cardiac tamponade is very, very important. What is that very important point in this cardiac tamponade raised JVP is, first and foremost, the Kussmaul sign will be absent, and there will be absent Y wave, right? There will be absent Y wave. And how will be the X descent? So there will be a prominent X descent in patients with the cardiac tamponade. So this will be the JVP findings in patients with the cardiac tamponade. So this is about your uremic encephalopathy. Then the next important nephrology emergency will be hypertensive encephalopathy. So hypertensive encephalopathy is that, why does this occur? That is because of decreased fluid excretion, or because of the fluid overload. right? Because of the fluid overload, there can be the hypertensive encephalopathy. And in case of hypertensive encephalopathy, how much will be the blood pressure? That will be more than 180 by 120 millimeters of mercury. Right. So now what will be the presentation in these individuals? So any encephalopathy, the manifestations will be the same. That is, they will be in a state of altered sensorium, they will be in a state of confusion, they will also have the seizures. Right. But the additional manifestation in hypertension as such, they can present with very severe headache. Right. Severe headache, confusion, altered sensorium, and even seizures. And not only that, these patients can also have the profuse excessive vomiting, right? Excessive vomiting. Okay, and you will notice that there is posterior reversible encephalopathy syndrome, and there is also bleeding in the back of eye, right? There can be also bleeding in the back of eye. So this will be the presentation in case of the hypertensive encephalopathy. And how will you diagnose? Number one, the blood pressure will be very high, and you have a characteristic EEG finding in patients with hypertensive encephalopathy. What is that characteristic EEG finding? Is that there will be absence of the alpha waves in the EEG. Right, there will be absence of the alpha waves in the EEG. Okay, so that is what you will see in the EEG. And next important thing is the treatment. So the treatment, what are the drugs that are very much preferred is, so the drugs that we can be preferably given in case of the hypertensive encephalopathy is labetalol. And this particular labetalol is what? It is both alpha plus beta blocker, and it is given as the intravenous bolus. So initially we give bolus, and followed by that we give infusion. And we also have the other drugs that can be given, even nicardipine. Right, nicardipine, it is an arteriolar vasodilator which is also given as an intravenous infusion, which is nothing but a calcium channel blocker. And we have few more, right? So we have few more drugs, that is clevidipine. So what is this clevidipine? This clevidipine, it is a short-acting dihydropyridine calcium channel blocker. It's a short-acting dihydropyridine calcium channel blocker. It reduces the blood pressure without affecting the cardiac filling pressures or causing reflex tachycardia. So reflex tachycardia will not be there, and as well as cardiac filling pressures does not get affected with your clevidipine. But the only problem is the availability. So availability is only the issue regarding this clevidipine. And the other drug that can be given is the phenoldiazepam. And even this phenoldiazepam also, the availability is an issue here. Okay, so this will be the treatment for the hypertensive encephalopathy. So two electrolyte abnormalities are hyperkalemia, hypokalemia, hypocalcemia, and hypermagnesemia. And CNS manifestations of nephrology emergencies will be uremic encephalopathy and as well as the hypertensive encephalopathy. Right. Then next, coming to the metabolic complications. The next important is coming to the metabolic complications. That is, there can be development of metabolic acidosis and as well as the dialysis related complications. See, these patients with chronic renal failure, they require almost twice or thrice the dialysis. Chronic renal failure, twice or thrice a week they require dialysis. And even these patients with acute renal failure, until that particular acute event is being corrected, they may be requiring dialysis depending upon the indication. Now, the dialysis complications are very, very important. Most common complication of the dialysis will be the hypotension. And what is the reason for the hypotension? Because you are taking a large volume of the fluid from the body and you are sending it to the dialyzer, and thereby the fluid volume reduces in the body, resulting in the hypotension. So immediately what you need to do is you need to stop that particular dialysis, right? And if required, you need to give the inotropic agents. Okay. And what is the most common complication of recurrent hemodialysis? This is another very, very important point. In case of recurrent hemodialysis, the complication that can be developed is accelerated atherosclerosis. And because of this accelerated atherosclerosis, the individual can have the ischemic manifestations. And in patients with dialysis, there can be also dialysis dementia. Right, there can be also development of dialysis dementia. Now, why is this dialysis dementia due to? Dialysis dementia is due to accumulation of amyloid beta 2 protein within the brain. Right, that is due to accumulation of amyloid beta 2 protein within the brain, and that will result in what is called the amyloid dialysis dementia. And this amyloid beta 2 protein is also accumulated in the flexor retinaculum It is also accumulated in flexor retinaculum in patients, and whenever there is accumulation of amyloid beta 2 protein within the flexor retinaculum, that will result in the development of carpal tunnel syndrome, right? Which is nothing but where there is compression of the median nerve. And the next important complication in case of dialysis is the loss of B7, right? Loss of B7. What is this B7? It is nothing but your pantothenic acid that is being lost during dialysis within the filter. And whenever there is loss of B7, the individual can develop the burning feet syndrome. Okay, the individual can develop the burning feet syndrome. Okay, so that is another important complication that you can see because of loss of B7, right? And another important complication is development of the myopathy. Development of myopathy. So these are all, the dialysis related complications. But what is the acute complication which requires immediate attention is the hypotension. Hypotension is the acute event which requires immediate attention, right? And the next very important complication is the metabolic acidosis. Okay, now what is the cause for metabolic acidosis? What is the pathogenesis for the development of metabolic acidosis in case of the renal failure? See, there are many mechanisms, out of which let me tell you one of the few important mechanisms. So one is loss of ammonia excretion, right? In patients with renal failure, there is loss of ammonia excretion. So in what way ammonia excretion and acidosis is being related? So remember, whenever ammonia is getting excreted, ammonia will combine with H plus ion which is present in our body, and it is excreted in the form of ammonium. So the H plus ion which is there in our body is excreted out, the ammonium is excreted out. So that is one mechanism. And in patients with renal failure, there is loss of ammonia excretion that will cause buildup of your H plus ion in the body, resulting in acidosis. And the next important mechanism for the development of metabolic acidosis in renal failure is due to due to increased bicarbonate excretion, right? Due to increased bicarbonate excretion. So bicarbonate is what? It is an alkaline substance. So the alkaline substance is getting excreted out in increased quantities. So what will be left out in our body will be acidosis, that is metabolic acidosis. And where is this bicarbonate reabsorbed? Bicarbonate is normally reabsorbed at the level of PCT, proximal convoluted tubule. And in these patients with acute tubular necrosis or in patients with renal failure, the bicarbonate reabsorption at the level of PCT does not occur, and thereby there is increased bicarbonate excretion. So there is no alkali in our body now to neutralize the acid, and that will result in the metabolic acidosis. Okay, right. So these are the two mechanisms for the development of metabolic acidosis. And now what will be the clinical features in patients with metabolic acidosis, right? A patient with metabolic acidosis will present to the casualty in a state of dyspnea, right? Severe onset breathlessness. And what is the mechanism for the development of dyspnea? Remember, whenever there is increase in H plus ion, which is nothing but decrease in pH, increase in H plus ion will go and stimulate the respiratory centers, right? Will go and stimulate the respiratory centers. Okay, so that is your pontine and as well as medullary respiratory centers. And once the respiratory centers are being stimulated, there will be increase in the respiratory rate. So the presentation can be in the form of dyspnea. And particularly if you take diabetic ketoacidosis patients, they can also have even vomiting, they can also have abdominal pain, and they'll have periodic breathing, that is called Kussmaul's respiration, and they'll also have fruity odor in their breath. Okay, so the presentation will be mainly in the form of dyspnea. Now the question is, when will you treat, right? And what is the treatment which is required? Okay, so treatment which is required in acute situations will be intravenous sodium bicarbonate has to be given, right? Intravenous sodium bicarbonate has to be given, right? Or if you want to give the oral formulations, you can give the oral sodium bicarbonate tablets, right? You can give the oral sodium bicarbonate tablets, or the another important solution we have, and that particular solution is called as Scholl's solution, which can neutralize the acidosis, right? Which can neutralize the acidosis. The other one is the Scholl's solution. And when will you give this bicarbonate is a very important question here, right? See, I'm not going into the depth of like your high anion gap metabolic acidosis or normal anion gap metabolic acidosis, but the indication for your bicarbonate therapy is that when the pH is less than 7, when the pH is less than 7, or When the bicarbonate value is less than 10 milliequivalents per liter, that is the indication for giving the bicarbonate. Now the question is how long you give this particular bicarbonate. How long you give this bicarbonate. So you have to give bicarbonate until the pH has reached to 7.2 from less than 7, or your bicarbonate it has reached up to 12 milliequivalents per liter. So until the bicarbonate has reached to from less than 10 to 12 milliequivalents per liter, you need to give sodium bicarbonate, and until the pH is reached to 7.2, you need to give this sodium bicarbonate. Okay, so that is the indication for your sodium bicarbonate, either intravenous or the oral formulations. The oral formulations will be oral sodium bicarbonate or even the Scholl solution we have, right? So this is about your dialysis related complications and metabolic complications that you can come across in patients with a chronic renal failure or renal failure. Okay, now the last important thing how I will wind up is I'll give you a clinical scenario, right, and you tell me the answer in the comment box, right? We will just see who will answer the best. A patient on amphotericin B has weakness and as well as cramps. Serum potassium is 2.3 milliequivalents per liter, right? Calculate the total potassium supplementation to be given to the patient over next 24 hours. 40 milliequivalents, 80 milliequivalents, 100 milliequivalents, 140 milliequivalents. So answer this particular question in the comment section. I will answer you back whether you are right or wrong. So with this, I'll wind up this particular session saying you that these are the nephrology emergencies that the patient can present with. Electrolyte abnormalities in the form of hyper or hypokalemia, then hypocalcemia, then hypermagnesemia. Metabolic acidosis, where the patient will present with sudden onset dyspnea. Uremic and hypertensive encephalopathy, where the patient will present with confusion, altered sensorium, seizures, right? And hypertensive encephalopathy, they can also present with headache and as well as vomiting. And dialysis related complications, very, very important, is the hypotension, right? So these are the nephrology emergencies where the patient will be presenting to you in the emergency, where you have to handle the patient in a very cleverly manner and treat the patient. Okay, so with this I'll wind up this particular session. Thank you very much. No, the sodium bicarbonate, see, you have to give this particular sodium bicarbonate, particularly you take in case of the diabetic ketoacidosis, right? In case of diabetic ketoacidosis, the target should be up to 12 milliequivalents per liter in diabetic ketoacidosis, whereas if it is not diabetic ketoacidosis, right, if it is not diabetic ketoacidosis, then in such case the goal of your bicarbonate that should be up to 22 milliequivalents per liter, right? 22 milliequivalents per liter. Okay, yes, masterization, is that clear? If it is DKA, your goal should be 12 milliequivalents per liter. Until 12 you reach, you need to be giving this bicarbonate. Whereas if it is not a case of your diabetic ketoacidosis, then if it is the other way around, then your target bicarbonate, it should be 22 milliequivalents per liter. Okay, right. So with this I'll wind up this particular session. Yes, yes, Zaidi, the Telegram group is, yeah, I'll just share that in the chat box here. Just give me a minute. So you can just download this particular PDF from this. Yeah, I don't know, it has come in the form of okay, so right, so I'll just post this PDF on my Telegram channel so you can download it from there. Okay, so thank you very much. See you in the next session where I will be discussing the emergencies related to the connective tissue disorders, right?